Look, I would like to thank everybody for coming tonight. I know that evenings are precious with family time and other things going on, so I do appreciate you coming and hearing me talk. I'd like to make this pretty informal. If you've got questions pertaining to what I'm talking about, just whack your hand up and we can get into a discussion. I asked a podiatrist, what do podiatrists want to hear from an orthopaedic surgeon? And the answer was, surprising really, was, who are orthopaedic surgeons? How do we refer to you? What do you do? That sort of thing, because I just assumed everybody knew, but apparently not. So that's my first talk. The second talk will be a little bit about foot and ankle surgery with some common cases, and the third talk will be cases, but I'm very pleased for people to also ask questions. Probably at the end is the best time. There's already been one question asked about injectables, and so we'll have a chat about that at the end. But I do want to make it reasonably informal. I'd firstly like to thank Medatis, who are the sponsor for this evening, so you can thank them for this beautiful food and beverages. And Michael from Medatis is sitting here, so thank you for that. And if you want to have a look, he's got a few of the plates and toys and things up on the sawbones up there if you want to go and have a quick look at that. I'd also like to thank Pam for all of her very hard work. You've probably received 1,000 emails and talks and things from her. And she's from Ramsden and Sunshine Coast University Private, where I operate. So a little bit about myself just for a couple of seconds. I'm a foot and ankle surgeon. I also do knees, but mainly foot and ankle. I started practice in Melbourne in 2020 and worked in a busy practice both in a private and public hospital.
2000.
Oh, 2000 I'll be about, yeah. I've been 20 years. And so during my time, I've looked after all facets of diabetes, foot and ankle, especially a lot of diabetics. When I came to the hospital where I worked down in Mornington Peninsula, no orthopaedic surgeon saw diabetics, and so when someone arrived, of course, bang, they all came to me. So I had a lot of busy work dealing with diabetics, so I'm very happy to see them. I've got a few toys up in my rooms, weight-bearing CT scan, as well as pressure-sensitive treadmill and pressure-sensitive insoles, all of which are very useful in the treatment of not only the diabetics but other facets of foot and ankle. So they're all available to me in my rooms. The other thing I'd like to say is, if any of you ever want to contact me, feel free. I realise that in this day and age, patients go straight to podiatrists, they don't go to their GPs, and so you're often the very first port of call. And if you think that somebody needs to be seen by me and you're not sure, or you just want to ask a question, or either ring or email, and I'm really happy to have a chat about it and share ideas. Because you'll be surprised how differently you think to how differently I think, simply because of our background and training. So that's something that hopefully tonight we'll be able to find a common ground. So what does an orthopaedic surgeon do? Well, clearly we operate, but that's not the vast majority of our time. You've got to consult to both see patients to organise operations, but also obviously with follow-up. So most of our time is spent consulting. Most surgeons would have either 2/3 or 3/4 consulting and the rest of the time operating. Private and public, here I did 6 months with a public appointment, but that was only a short contract and hasn't been renewed since COVID. So I'm just in private at the moment. I'm a single surgeon. I don't work in a group, mainly because of just the background. In my practice in Melbourne, where I was for 20 years, I used to have a podiatrist, an orthotist, a physio, a nurse, my CT scan and my treadmill. So I took up 5 rooms, so there was no room for anyone else. So I've just come up here, totally unknown, so I'm just on my own. And general versus subspecialist. And as far as I'm concerned, the subspecialties are here and embedded in our orthopaedic world. There's too much to know everything. And if you're out in the country or something like that, that's fine. But when you're in, a city sort of atmosphere with lots of orthopods around, I really think that subspecialties are going to take over. And there's criticisms about that, but I really think that's the way to go. with respect to patients that come and see me, I would only operate on 10 to 20%. Now, different specialties have different percentages, and different surgeons might operate on more. Shoulder surgeons tend to operate on more, but in foot and ankle, there are so many conditions that never end up in surgery. Plantar fasciitis, synovitis, mild osteoarthritis, these sort of things, biomechanical things. So most of my patients don't end up with surgery. So if you think, should I refer to this guy? He's a surgeon, he'll end up with an operation. That's not necessarily the case. And I can only speak for myself. I don't want to speak for other people. But usually we'll start with non-operative measures and you work your way up. There are some conditions where surgery is the only option, and if that's the case, I'll tell the patient. The classic condition for me, where surgery is the only condition, is an osteochondral lesion of the tail. So someone presents and they chip the cartilage in the bone and the tails, well, you've got to go in and fish that out and clean it up. Ruptures of tendons, that sort of thing, usually need surgery. As far as what I've had to learn through my way, and without meaning this to be no, we know a truckload of stuff. We've studied extremely hard, spent a long time doing it, anatomy, physiology, biomechanics, rehab psychology, and then you get thrust out in the real world and you have to learn all these other things like small business management. No one ever taught me about work cover. All the stuff that I guess if any of you run your own clinics will have had to have learned. So, orthopaedic surgeons, despite their arrogance, are smart people. You can't be an orthopod unless you're smart, or a smart aleck. So how do you become a surgeon? Basically, you study like crazy and work like a dog. You need to get the top marks at high school to get into the university. Then in university, you have to get the top marks to even get considered. You sit a surgery exam, the College of Surgeons exam, and that's sat through Australasia, and only 25% of people pass. They just say, right, these 25%, the rest fail. Bad luck. And it took me 2 goes to sit it. 12 months of study, 4 hours of study a day, 12 months of study, 4 hours a day, and you're working full time during that time. So, and it was the very first thing I'd ever failed in, basically schooling, university, and that sort of thing. So it's heartbreaking. And you then got to get back on the horse and re-sit. So once you've done it, you've then got to apply to orthopaedic training. And if any of you know the public system, there's 13 or 14 registrars. All of them are vying for one trainee position. So it's unbelievably competitive, and it may take several years to get into the program. Once you're in, usually you then do 4, it's now 5 years. You've got to be working and studying. The hours are not as long as when I went through, but they're still pretty long, especially on call. And then you've got to sit your second part exam, which is the big one. And that takes 12 months of continuous study again. The pass rate's pretty high. They want to pass you. They don't try and fail you there. And then once you've done all that, you then need to go and do some subspecialty training, usually 6 or 12 months overseas. So it's a very long, hard road. I went straight from school, and I didn't finish my training until I was 34. And by then all your friends are off having babies and having jobs, and if you've got a friend who's a tradie, they're already on their second house and that sort of thing, and you're just basically starting your career. Despite all of that, it is a lot of fun. I get a great deal of joy out of orthopaedic surgery, not just the operating part, but there are some great gets. And when you've got a diabetic, for instance, who's about to have their foot lopped off, and you can save that. If you've got a patient who can't walk around the block, and his wife's about to divorce him, you give him a total knee joint replacement, suddenly it's a happy marriage again. So it is a very rewarding job. And there are life-changing surgeries we can do for patients. However, the buck stops with me. None of you will ever be named in a court proceeding or a liability suit, yet my name is always on top of the list. So I have to be aware that people look to an orthopaedic surgeon to make decisions. There's a saying about surgeons that not always right, but never hesitant. And you have to make a decision, and if it's wrong, well, that's the way it goes. But you can't sit on the fence, because we're the end of we're the apex of the pecking order. goes from you guys to GPs and other modalities, and in the end, someone says to me, listen, what's your decision? And as I said, we're not always right, and I've learned plenty from podiatrists and physios and other paramedicals in discussions. I can't keep up with all the latest reading and things, and we used to have my other practice, I had a wound nurse who came to the rooms, and goodness me, did I learn a lot from her, because she was right up with all the wound technology and the wound changes, and it changed my practice. As with you, we have to do further education along the whole way. So, you have to get your points, go to meetings and give talks and all that sort of stuff. But the best thing for me is that I'm my own boss. And if I didn't want to go to work tomorrow, I can just ring my secretary and say, listen, cancel all the patients after she's had a heart attack. The bottom line, I can do that. So, to me, that's a very powerful thing. And I hear so many surgeons who say, oh, I'm so busy, I can't do this, I can't do that. And I said, well, talk to your boss. Oh, that's you. And so anyone who says they're too busy as a surgeon has no one to blame but themselves. And again, similarly, if any of you own your own clinics and you're working too hard, have a look, because you've got to enjoy life. I'm a big enjoyer of life, and especially sport and things like that. And coming up here has just been fantastic, because I've now got the weather that I can get out all year round rather than just 3 or 4 months of the year. I'm very big on research. As I said, I've got those toys on my rooms, and I'm open to anybody who wants research projects. I'm not looking to make money out of any of this stuff. If you've got a great research project you want to come in and do, I had a couple of master's students did a really good study of barefoot running versus shoe running on my treadmill. It got published, they did their masters, and it was fantastic, and I learned a lot from them. So I'm really happy for the equipment to be used. If anyone has any ideas, I'm very big on research. And as I said, you're your own boss, so if you're working too hard, it's your own fault. This is the general versus subspecialty argument. No individual can know everything, apart from the fact there are areas you might hate. I can't stand spines. I just find spine patients difficult. I find spinal surgery extremely difficult, and I basically have said I'm not even registered to do spinal surgery, so it means that no one can send me one. There might be areas of need, and certainly in podiatry you guys will have different emphasis depending on where you practice. If you're out bush, obviously diabetes and with the Indigenous personnel and that sort of thing. You might specialise in women's problems, So in that respect, especially, it hasn't hit here, I don't think as much, but in Melbourne, obesity was a massive problem. And it does really extend to foot problems being exacerbated by obesity. And so, you might be someone who not only looks after the feet, but he runs a program to address people with weight problems. Group practices are becoming much more common. As I said, I'm not part of one, but just above me in the room is the other orthopaedic group, and they've got shoulder, knee, hip, and that makes sense as well, because you can cover all of the different parts of the body and cross-refer. I'm very big on multidisciplinary though. I'm very big on having the paramedicals such as podiatry, orthotists, physio, all that sort of stuff, all in one spot, because it means that the patient has a one-stop shop. When someone comes to my room, so the nurse will take the plaster off, I'll do their CT, the physio or podiatrist will see them, fit them with a boot, the compression stocking, and give them exercise to go on. And it's all in one appointment in my rooms. They don't have to go to 5 different spots. And so I'm very big on multidisciplinary communication as well. For instance, if you refer me a patient, every time I write a letter to the GP, you will get one too. You're part of the whole treatment program. It's not compartmentalised. So, you're as important as I am in the whole picture, because you're the one the patient's going to be going back to more regularly. I'll do my bit, might see them for a while, but in the end, in 2 years' time, then you're the one who's going to be seeing them every 6 or 8 weeks or whatever they need, depending on the problem. So, I just assumed everyone knew how you get to see me. In Australia, you have to have a referral from a GP. You're not allowed to refer physios aren't allowed to refer. The only other people outside of GPs are nurse practitioners, and there's not many of those around. Now that's not to say that I don't want to know what you guys think. So let's say you see a patient who you want to see me. What you need to do is write me a letter yourself. All right, it doesn't have to go via GP or anything. You write a letter saying, "Dear Jared, please see this thing, so and so, they've got this problem." Now, in order to get a Medicare rebate, they have to go to a GP because I'm not allowed walk-ins. It's against the law. So what you need to do is say, go to your GP, and some GPs will just write the letter without saying the patient, but most of them these days will say you have to come in for an appointment. That's their decision. But make sure you write me a letter yourself so that I know what you think, because the GP won't. They won't know. Because the patient will go, "My podiatrist says I need to see Jared Burke, can you write me a referral?" The GP say, "Yeah, fine, here." Right? And they're going to write, "Please see so-and-so with a sore foot." Okay? So it's really important that you write a letter. And I'm very happy to, I had a lot of pods that I developed a relationship in Melbourne, and my secretary knew that if that person rung, put them straight through. So I'm very happy to be involved with you guys. If it is urgent, then make sure that the receptionist or Kelly, who's my secretary, knows that it's urgent. If you've got a patient with an acute Charcot, an ulcer that you're worried about, that sort of thing, a tib post rupture, anything like that. Now at the moment it's easy because I'm not that busy, but if I get busier, say, "Listen, I think this patient needs to see Jared this week." Okay? So don't be afraid, if you know that it's urgent, make sure that everyone else does. Don't be afraid of standing up for yourself. In terms of costs, usually most people, I charge $200 for an initial consultation, and I think they get about $76.50 back. Private insurance doesn't help with normal consultations, all right? So it doesn't matter who you are, it's the same cost. Now, again, if you've got a patient who is, especially at the moment, who's really struggling, you've got, they've got much, tell me, and I'm not going starving, so I'm aware that there are people out there who need to be looked after. And, Kelly will tell you, I know, don't worry about it, we'll just bulk bill them today and that sort of thing. So, in that respect, don't be afraid of saying, is it possible to look after this patient or bulk bill them or whatever else, reduce the price because they're struggling. And I'll understand. The worst thing that can happen is I'll just charge my normal fee. But don't be embarrassed. I'll see work cover. Well, TOC doesn't exist in Queensland. Veterans, all of that. I've got. I don't restrict my patients. In terms of how much a patient needs to pay if they come to surgery, the health system here, the private system here is incredibly complicated. Every insurance company virtually has its own fees, and some will allow the surgeon to charge out of pocket, others won't. And if they're one of the ones that won't allow it out of pocket, the moment I go above what they say is their prescribed rate, they'll pay 3/4 of what they would pay. Which, it sounds unbelievable, but the insurance company will pay according to how much I charge. And if I charge more than what they think is I should, they drop down the rate the patient get, which is a double whammy for the patient. Okay? And the problem is that most funds are different. And it's criminal, and I don't know how it's got through, but that's just the way it is. So in terms of how much a patient has to pay, it's very difficult to calculate, and we spend a lot of time doing quotes. By law, a surgeon has to provide a financial consent, and that means to provide an estimate of costs out of pocket before the surgery. And we get patients to sign and that sort of thing. With me, because I've been around a long time, mostly what I predict is what ends up happening. And 90% of patients, we don't change the fee. But clearly, if you find something in surgery that's unexpected, then they might have to do more. If sometimes you do less, and they pay less. But a patient who has surgery, the surgeon will almost certainly charge out of pocket, some don't. The anaesthetist will always charge out of pocket. I've never heard of one who doesn't. Assistant surgeons, if you have insurance, I make my assistant not charge anything out of pocket, because I reckon they get paid well enough without doing anything. No response, who does walk in and walk out. There are exceptions. There are some nurse practitioners on the coast here who assist, and they're not covered by private insurance, so they have to charge out of pocket. We've been lobbying certainly the government over time so that they can get the same rights as GPs, because they've had to do a lot of training. Some surgeons allow their assistants to charge 1/5 of what they charge, which means that the patient is out of pocket. And I'm philosophically objecting to that, but that's a personal choice. So the hospital cost will depend on their level of insurance. So if a patient has an excess as part of their insurance, they'll have to pay that. It depends on their level of cover. Some don't have excesses, some might have a yearly excess, some might have an excess every time they go. And then obviously the ancillaries, and you guys know all about extras and high caps and all that sort of stuff, and what do you call it, the GP thing,
Care plan.
care
plan?
Yeah, except care plan, the ECP. So in terms of patients paying, there are a lot of costs, and I'm aware of that, and especially retired people with fixed incomes, they might be on a tight budget. So it's very important that, for me, that we try and tell the patient exactly how much they're going to be able to cost before they go in, so there are no bad surprises. But again, you can tell the patient, listen, you are going to be out of cost. You're going to, a surgeon, anaesthetist. In my case, not the assistant. Depends on your hospital cover. Plus, if you then need, cam boot, compression stocking, orthotics, all that sort of stuff post-op. This is just a little bit about how much they pay and what I was saying about the gaps. But we must provide, the bottom line is that by law, we have to provide informed financial consent before we start. And this is the hospital costs are only covered if you have private insurance, so the uninsured patient has to pay a lot, because hospitals are the most expensive part. For instance, an ankle arthroscopy, the patient would expect out of pocket just for the hospital to be $2,500, whereas for the rest, about $1,000. So that's the surgeon, and that's out of pocket, because the hospital doesn't get any Medicare. Whereas if what I charge, Medicare will pay a certain amount. So for say an ankle arthroscopy, a patient would expect to be about $3,500 out of pocket, $2,500 of which is the hospital, because they charge a theatre fee plus a bed fee. And so obviously for uninsured patients, we try and minimise the hospital stay. So it's about $1,000 a day. So often, I'll say to a patient, I can do this under a block. You'll go home, but when the block wears off, you'll be really sore, but it's going to save you $1,000. Ancillary, like you know more about the billing of podiatry than me, but obviously there's the high, extras and high caps and the ECPs. And I'm a big ECP. I'm very happy to sign the form. I know some orthopods can't be bothered and don't work, but I used to sign multiple forms every week to help the patients. Well, they get, is it six visits or something? 5. So your role as primary caregivers is basically to decide who you think needs to come and see me. Because a lot of stuff you guys look after and I don't need to see, and I probably don't want to see. So it's the ones that you think need either an opinion or treatment from me. As I said, what I'd like you to do is to recommend to come and see me, get them to go to their GP for a referral, but I do want you to write me a letter, okay? I don't care if it's handwritten, whatever. Now, as far as your referral letters are, keep to the facts as much as possible. Avoid jargon, only because your jargon is different to my jargon, okay? I mean, in terms of, when I talk to podiatrists and they start talking, I've got to sort of slow down and say, I'm trying to translate a different language. and yet we're all talking about the same thing. I mean, the classic is hallux rigidus. Now, it's a common thing most orthopods now to talk about hallux rigidus, and everyone knows what I'm talking about. But when I first started, no one would have ever said hallux rigidus. That was a podiatry term. It was always first MT-PLA. And now, because of the mesh that's come in, and with some of the cases later on, I'd like to get you guys feedback about this is what I call this. What do you call it? And flat feet is the absolute classic, because there is just no consensus amongst the world on how to describe flat feet. Okay? So try and avoid jargon. I'm very big on writing longhand, basic words of one syllable less, so that everyone knows what I'm talking about. You know, I'll say the toe is pointing up, or, you know, because if I talk about supination and pronation, or hindfoot valgus and varus and abduction and midfoot collapse and things like that, you don't know what I mean by that, because my meaning might be different to yours. So I'm very big on writing, this is the problem, and this is what it looks like. If you think you know the diagnosis, by all means say it. I mean, don't be afraid, it's not a test. And if I disagree, you know, that's fine. If I agree, then I'll give you kudos in the end. You know. So if you, we're always taught when you're taking history as a medical student, if the patient tells you the diagnosis, ignore it, because they could be wrong and it leads you up the garden path. But I'm sort of been around long enough that I can make my own decisions. And the first thing I tell the patient is, tell me the story in your own words. I don't want to hear what the podiatrist, GP, physio told you. I only want to hear what your problem is. If you have a specific question, and often you do, absolutely underline or something. Make it clear that is the question you want me to answer. I'm not psychic, you know, and I want to help you. And, not so much me, but if you are referring to other surgeons, and clearly you're going to, if you want something in particular, and the common one for me is if someone wants somebody with a cortisone injection, it doesn't hurt to stroke their ego just a little bit. You know, say, you know, we really value your valuable opinion and we appreciate, you know, all that sort of stuff. That's if you want something in particular. And as I said, cortisone is the main one. Anyway, so look, in terms of the most common procedures, this was made in Melbourne, and bunion and claw toes comes way down the list on the Sunshine Coast because no one wears shoes. But bunion and claw toes, bread and butter. I did my background in sports medicine. I was part of the sports medicine training program when I first started. But my average patient in Melbourne was a 50-year-old woman with bunions and claw toes. Ankle arthroscopy, there's a lot of condyle lesions and impingement. Midfoot arthritis is very common up here, and I'm seeing a lot of that in the sort of middle to older age. Ankle reconstruction, again, a very common injury. Lateral ligament reconstruction mainly. We are seeing more deltoid ligament now, but you know, lateral ligament reconstruction. I do knees, so I do these other things in the knee, which you may be asked about by patients. Oh, sorry. There are certain operations that are winners, and hip and knee replacement, I don't do hip replacement, but they're winning operations. So if you've got a patient who's asking you about a knee replacement, because I know that they do, they ask you because, you know, you're treating their feet and they say, oh, you know, my dad's going for a knee replacement. Knee replacement is a winning operation, and it can change life. Ankle arthroscopy, again, is a winning operation. Usually you're treating an osteochondral lesion or impingement or something of the like, and it's very rapid recovery, low rate of complication, and you know, it's a really good procedure by and large. Foot fusions for severe arthritis, and I underline the word severe. Midfoot arthritis generally doesn't get bad enough to warrant an operation. Most people can live with it, and it will just remain plateaued for a long, long time. But for those patients who have severe midfoot arthritis, can only walk room to room, have pain at night, that sort of thing, it's, again, a life changer, because suddenly they can, you know, do their hour around the block or the supermarket, things like that. For backs, acute discectomy, again, if you've got a patient who's got foot pain, but you think it's coming from the nerve root being pressed, that is a very good operation, and I can attest to that. I've had it done to me twice, and it's saved my life. So, because you will see patients in whom you don't know where the pain's coming from, think about the back, okay? because it's not always foot pathology. And you know, I'll see a patient every month or so, and I'll send off to the spine guys for an opinion. Ankle reconstruction again is a good operation to get people back on the field. Ones that are not normal and not always good can be fantastic. Ankle arthroplasty. So I've done over 80 ankle joint replacements. I've slowed down enormously, which is the general trend in Australia. I used to do about 15 a year, and now I'll only do a couple. And in fact, no one's done one on the Sunshine Coast that I'm aware of. It can be fantastic, but it can also be disastrous, and it does have a lifespan. And I tell patients who are only last 10 years, then you need to have a revision or something like that done. So ankle arthroplasty can be fantastic, and you know, you've got those patients who come in with really bad OA pain, but their ankle moves like this, you say, well, I'm going to fuse it, their jaw drops to the ground. And I understand why. Patellofemoral problems can be fantastic, but again, plantar fascia surgery. Now, the literature would say that only 80% success. I must admit, my personal success seems a bit higher than that, but I'm very selective. If I see 100 patients with plantar fasciitis, about 50 will get a cortisone injection and 5 will get an operation. Everybody gets all the exercises and stretching and all that sort of stuff. And I do mine through an endoscopic procedure, which has been a bit of a game changer. It's much less morbidity from the scar. It's not a more rapid recovery because remember, you've got tiny cuts in the skin, but you're still cutting an inch across from the plantar fascia inside. So it still takes a while to recover. But it's usually very good, and I do one and I get a great result. Gee, I should be doing more of these, and then I'll do one and the result's not so great. And you've got nowhere to go. You know, I've got no more answers. The patient has still got heel pain after plantar fascia surgery. Either I've got the wrong diagnosis, or I don't know what. And then the spinal and knee stuff. You know, this is very important, and I have to remind myself of this every day. No condition cannot be made worse with surgery. So you have to earn an operation, because I can assure you, even if the complication rate is 1%, if you're in that 1%, you're a very unhappy camper. And you know, you only have to have a nerve cut, you have to have a bad infection, a non-union, any of these complications that do occur, I mean, everyone gets them, it really turns a good operation bad. So you've got to be bad enough to warrant an operation. You've got to look at the risk-benefit analysis. So for those orthopaedists operate on everyone, you know, they're going to be doing unnecessary surgery and they're going to get more complications than they need. Patient choice to me is the most important. You've got to choose who are the good patients. And you would see these people around who come in and you know that if they have an operation, they'll do poorly. You know, they're never going to be right. A lot of work couple patients are like that, unfortunately. Or they're the sort of people who come in with bunions and you know they're getting their surgery for cosmesis, not for pain, and they'll never ever be happy with their foot. So patient choice is as important. Rehabilitation is the other really important part of my practice. And it's all very well for me to do the surgery, but if they don't do the right rehab, if they don't elevate their foot, if they don't non-weight bear, if they don't do their mobilisation and they get a stiff joint, it's all a waste of time. So that's where you guys come into it in terms of, you know, looking after the patient after the surgery to make me look good. One of the things that I've found that's different between doctors and you know, pods and physios and that, we spend a lot of time in our medical school days learning how to take a history and get a diagnosis. And I'm not sure whether it's changed, but certainly in the early, you know, my early career, the diagnosing part of it was very difficult for physios and podiatrists and others. And I'm hoping that's changing as years go on. So to me, in terms of the diagnosis, history is the most important. And they say that you can diagnose 90% of people over the telephone. And especially if you've been around for a little while like I have, people say key things and your ears prick up and you think, oh, that's probably what that is. Now you have to remain alert because it's not always the case. And then I use examination and investigation to confirm it. Never be afraid to say, I don't know what's wrong with you, especially for an ankle. because there are so many weird pains that come and go. When I was in sports medicine, someone once said, most things get better on their own, you've just got to be around to take the credit. So I'm not afraid of saying, all right, I don't know what's wrong with you today, let's do this and this, and you might put them in a boot, you might give them some exercises, I might organise an x-ray, come back in 10 days and see you again. When they come back, you start from scratch and say, what's the problem? And they might give you a different answer, a different, and you get different information. It's a bit like when you see the cop shows and they keep asking the same question and then suddenly it gives a different answer. So it's really important that you don't have to make a diagnosis and provide treatment that day. I mean, the market forces aren't that strong. Say, I don't know what's wrong with you, I think it's this, or it could be 3 or 4 different things. Let's do this and see how you go. Write down a pain diary, or come back and see me in a week. Start from scratch then, and often you'll find that they'll come out with some pearl that they didn't remember last time. Or they've gone home and thought about it and said, oh yeah, I do remember doing this. And re-examination is also very useful. Is it consistent with your previous examination? The other thing, which I'm afraid many orthopods, especially the sports guys, are doing, is making up new diseases and diagnoses. Medicine has been around a very long time with some very clever people who kept meticulous notes and observations. We're nowhere near as good as those people were. And there aren't many totally new diagnoses around. They're usually generally variations on the same thing. So don't make something up thinking that you're the first person that's ever seen this in the world. Have a good literature search, and often in a paper in the 60s or 70s, someone will read it up, but it's called something different. So just be aware, if you see something that is totally new, never seen it before, don't be afraid of saying to the patient, listen, I'm going to ask my colleagues, I'm going to research it up, and that sort of thing. Maybe you will be the one who makes this new diagnosis and get your name on a disease, but there aren't many around, I don't think. The other thing to remember if you are suggesting surgery to a patient is it's a big deal. I don't know if many of you have had operations, I've had lots in my time. It is a big deal. You have to plan ahead, especially foot surgery. You've got to put your foot up after the operation. If it's your right foot, you can't drive for a number of weeks. You're going to take time off work. It's going to swell, it's going to hurt, it's going to be very inconvenient for you if you've got something coming up. For instance, if someone had pre-COVID an overseas trip planned, I would not operate within 3 months unless it was something really minor. Because I had one woman once who had complications, had to cancel the trip, and my heart just sank. So just be aware that it is a big deal to patients to have an operation. And the other thing you need to do is make sure that their expectations are realistic. Don't expect to have a new foot and to be able to walk 20 k's around the block. And, the number of times a patient may say, oh, I'd love to run again. You say, well, when was the last time you ran? Well, 10 years ago. Clearly that patient has far less chance of running than someone who's only had to give up a month ago because of their foot injury. Mr. Google is infiltrating our life in many ways, and again, it's disconcerting when patients come in with pages and put them down on your desk and they've just printed straight off the computer, and you guys must get it as well. Be confident in your training. You've trained, you're experienced. Don't let Google and other sort of funny diagnoses and things sway you, especially, oh, but my brother had this and he didn't have to have this treatment or whatever else. He probably didn't have the same thing. Orthopaedic surgeons don't know everything, and to be quite honest, we're an arrogant bunch, and many have forgotten that they don't know anything. So if you disagree with something that I say, don't be afraid of sending them off to someone else for a second opinion. Okay? If an orthopod's afraid of a second opinion, then it's their problem, not the patient's. You want to do the best thing for your patient, which means that if you think that the surgeon you've sent them to, including me, is not handling them the way that you want, send them to someone else. All right? It's a buyer's choice in this market. And the two things you need in a surgeon is, one, obviously skill, but you need to be able to talk to them as well. If there's a problem after the surgery, I need to know, And I need to be able to get the patient in and say, listen, what's wrong? Not, no, it's not my problem, go to the GP. You know, or, I can see you in 6 weeks, that sort of thing. So if you find that you're getting that sort of input from people you refer to, whether they're surgeons or other people, then there's always someone else. Obviously, you need to make a decision. There's no point in sending me, a 96-year-old with cardiomyopathy, peripheral vascular disease, and say, can you fix his bunions? Because, clearly that patient is not fit for a haircut, let alone an operation. Also, part of your job will be helping with the perioperative supports. I had a lady who's having a big foot operation. She lives in a villa. Her bedroom's upstairs with the only shower. And I said, well, you won't be going upstairs for 6 weeks. You're going to be doing weight bearing and plaster. You're going to move a bed downstairs. And that's, So you have to be able to be aware of the restrictions the patient's going to have on them so that you can help them plan for their surgery, because pre-operative planning determines the outcome in so many cases. So it's really important that post-operatively you guys are aware about walking aids, about different shoe types that they might be able to go into, especially if they're swollen 3 months after surgery. They say, I can't fit into my shoes, but I've got to go to work. What can you do to help me? So part of that will be, because I can't help you with that. You've got a much better idea. You need to know what brands of shoes are going to fit, how you can source them, funding, that sort of thing. And don't forget also that most of them are scared. And, anyone who's not scared going to surgery is stupid, because it is a big thing to do. And as I said, I've had a lot of operations and I spent half my life in theatre, but every time I go in, my heart rate goes up. And anyone who's not nervous about surgery, the problem is, they've got a problem, and I'm a bit reluctant to operate. Hospitals are scary places. It's a bit like me going to the dentist. I only have to walk into the dentist and I get the shivers. So hospitals are scary, and operating theatre is very intimidating these days. Almost all patients go in without a pre-med. When I was a little boy, they used to give pre-meds, and the patient would be half smacked by half salt by the time they get wheeled into the theatre. Nowadays, there's very much more no pre-med, and they can get out quickly. Be aware in your patients that anaesthetics knock you around. There's nothing natural about being put to sleep. And anyone who's having a big exam or a big test, don't have their surgery within a week of that test, because studies have shown that your cognitive ability is impaired for up to 10 days. So especially for VCE patients, year 12 and university students, make sure they don't have their operation the day before their big exam. Patients who are operating heavy machinery and things like that, make sure that they're aware they need to take a few days off, even if physically they're able to do it. They may not have the judgment. Tradies who are walking on roofs and climbing ladders, they may think they'll be able to do things, but next thing you know, they've fallen. Chronic pain makes people crazy, and I'm never sure whether the crazy people are crazy and then get pain, or whether the pain makes them crazy. But there's no doubt that chronic pain makes people crazy and irrational. So be aware of that, and respect the fact that most people don't make it up. If they say they're in pain, they really are in pain. So you've got to be aware of that and believe them when they say it. Complications frustrate and anger patients and relatives, and for my part, I've got to think about medical legal side. I don't want to get sued, but you've got to also try and explain why did the complication occur. Everyone wants to blame someone, but there are plenty of complications that are no one's fault. I don't know if many of you have seen patients with full-blown chronic regional pain syndrome, but it's a total disaster. It's just incredible. They're painful, they're swollen, they're hypersensitive, they can't understand what it's about, trying to explain this weird phenomenon, but it's not your fault, it's not their fault, it's going to take a year or so to get better. It's very frustrating, and often you have to see the patient a lot of times and keep going over the information over and over and over. And with a condition like that, tell them don't look on the internet, because there are so many wackos who sit there and just write doom and gloom stories. So be sympathetic, because if I've got a complication, unfortunately you will share in it as well. I'm very big on evidence-based medicine, and hopefully you guys are as well. I know podiatry, I used to go to the American Podiatric Surgery meeting each year, And their meetings are full of case studies. We've got one case study of this, and they're useless. A case study is useless. What you need is some sort of a longitudinal study, level 1, 2, or 3 study, that sort of thing. So just be aware that when you're reading literature, case studies are all very well, but they really don't tell you much about what's going to work in the general population. The other thing to watch out is studies that are funded by the companies. And there are a lot of conditions in which you have to be funded because they're so big, but the 99% success rate by the guy who designed the implant, and yet everyone else can only get 65%, you've got to ask questions. Your practice is swayed by your last disaster, and stick to your guns. If you've had a patient that you've treated in a certain way and it's all gone pear-shaped, but you know that's the way that you should have treated the patient, when the next one comes along, don't change, or change a little bit, but don't suddenly throw that treatment modality that you've used successfully in the past out just because you've had one disaster. Okay? And whether that be with a technique of taping and orthotic, for me, a surgical technique. When you're looking at journals and articles, always assess who's it come from. Do they have a vested interest? Are they reputable? There's a lot of stuff comes out of, for instance, orthopaedic literature out of Italy. And unless you go over to Italy and you see the hierarchy where you've got the professor and all these underlings, and they're all sucking up to him because if they give him a bad word, they'll never move up the hierarchy. So whatever the professor says goes. And the patients are likewise. Germany's typical of that as well, where, you're good, aren't you? Yes. And the patient's too afraid to say that they can hardly walk. So have a look at the level of evidence, who the authors are, is it a good journal, and be aware of results that are too good to be true. And I'm a big one for questioning theories, and Morton's uroma is a classic one of those. I did when I was a second year resident, a study where in those days we still had a morgue at the hospital, so whenever someone died, I'd rush over to the morgue and I'd cut out their third interdigital space, bones, nerves, a whole bit, and we'd send them off for histology. And the vast majority came back as Morton's uroma with degeneration. Yet these patients, none of them had foot pain. So, in terms of that, we don't know what Morton's is. If you don't know what's wrong, then treat generically. Ask your colleagues. If you've got good resources on the internet, that's fine, but be wary about, this guy who's world renowned over in America and all that sort of stuff, because they've got, a lot of vested interests. And nothing spoils good results like follow-up. So hopefully that's been a bit of an outline of, who I am and what orthopaedic surgery is about. If you've got any quick questions on that, we'll take those before you dig into the main course, and then I might get straight on to the second talk because I've been much longer there than I thought. So any questions just about what I've just said?
I had a question about the plantar fasciitis surgery.
Yeah.
Might be a bit ignorant, but what do you actually do there? Is it just...
Well, basically I do it endoscopically, so I make an incision on the medial side, and you put in an arthroscope with the camera, and it's got a blade attached that can do that. And I'll just pull it back and divide the longitudinal fibres. Now, when I first learned to do this, the way we learned to do it was on cadavers. So we'd go and do the procedure endoscopically, then we'd dissect the cadaver to see how much we'd actually divide it. Because, of course, if you cut the entire plantar fascia, you're in danger of just going flat. There are so many layers of the plantar fascia that there is no way you can cut them all just with this little instrument. So I was pretty happy that even though we were cutting a certain percentage of the fibres, I've never had anyone go entirely flat. The only time I cut the entire plantar fascia deliberately is in someone with a cova-varus foot, so Shakamura tooth or something like that. But otherwise, if you do it endoscopically, you just can't cut them all. And they come off the calcaneus in a whole lot of layers. It's not just one little layer.
So enough just to get some relief from tension?
Hopefully.
And then is that like a day procedure?
Yeah, in and out same day.
Yeah.
I get the patients to partial weight bear on their forefoot for a week or two after the surgery, simply because if they weight bear on their heel, I'm afraid they'll get a big hematoma and it'll take weeks and weeks to recover. I'm sure they do walk in the heel, it's pretty sore, but I say that for the first week or two, 50% partial weight bearing with 4 foot crutches, and then come back, have the stitch out, and away you go. It's still the same length of recovery as an open procedure because you're still cutting this much inside.
Yeah.
But you don't get the nerve problems of the wounds are often very tender in open plantar fascia releases. So I never used to do it, but now I'll do. You've got to have had 12 months of treatment and fail with conservative measures and all that sort of stuff.
Yeah, of course. Yeah. Thanks.
All right, we'll dig in and I'll get going again with the second talk in just a couple of minutes.